Hello, everyone. My name is Dr. Simran Agarwal, and I am an internal medicine resident at Broward Health. Today, I'll be presenting our case when one diagnosis is not enough progressive dysphagia revealing concurrent ischemic stroke and gastroesophageal junction adenocarcinoma. Our patient was an 82-year-old Russian speaking man with a history of hypertension, AFib on anticoagulation, and a prior TIA. For approximately 3 weeks prior to admission, he had experienced progressive dysphagia, primarily to solid foods, while maintaining the ability to tolerate liquids. His symptoms were associated with postprandial discomfort, poor oral intake, generalized weakness, and an approximately 10-kilogram unintentional weight loss. He had already been scheduled for an outpatient endoscopy to evaluate these symptoms. However, what ultimately brought him to the hospital was an acute change in his condition. He developed confusion, worsening generalized weakness, and sustained a fall, prompting hospital evaluation. So, at presentation, we were therefore faced with two different clinical patterns: a progressive GI syndrome characterized by dysphagia and significant weight loss, and a more acute neurologic presentation characterized by altered mental status, weakness, and a fall. Initial lab studies did not identify a clear metabolic explanation for his encephalopathy, and a non contrast CT of the head was negative. At the same time, CT of the abdomen and pelvis was obtained to investigate his progressive dysphagia and weight loss. This demonstrated abnormal gastric wall thickening with an approximately 2.8 centimeter lesion concerning for neoplasia, prompting inpatient GI evaluation. Rather than attempting to unify all of his symptoms under a single diagnosis, both diagnostic pathways were pursued simultaneously. From the neurologic standpoint, concern remained despite the initial negative CT head. Following the stroke protocol, MRI of the brain subsequently demonstrated an acute left posterior cerebral artery distribution infarct. CT of the head and neck demonstrated severe vertebral artery disease, and subsequent diagnostic cerebral angiography confirmed complete right vertebral artery occlusion with diffuse vertebrobasilar atherosclerotic disease. No intervention was indicated, and the patient was managed medically with secondary stroke prevention. Simultaneously, gastroenterology continued evaluation of his progressive dysphagia. EGD demonstrated a malignant appearing gastroesophageal junction stricture with severe esophagitis and gastritis, and biopsies were obtained. Histopathology ultimately demonstrated poorly differentiated adenocarcinoma involving the gastroesophageal junction and gastric cardia, with signet ring cell and mucinous features and HER2 negative disease. Staging evaluation did not demonstrate definite distant metastatic disease, and multidisciplinary evaluation involved gastroenterology, neurology, interventional neurology, medical oncology, cardiothoracic surgery, nutrition, palliative care, and of course, internal medicine. Ultimately, the patient's presentation was not the result of a single unifying disease process. His progressive solid food dysphagia and substantial weight loss were explained by an obstructing gastroesophageal malignancy, while his acute neurologic change was explained by a concurrent left PCA ischemic infarction in the setting of significant vertebrobasilar disease. This case highlights an important principle in clinical reasoning. Multiple diagnoses can coexist. There can be a strong tendency to search for one diagnosis that explains every symptom. However, when the timing or character of different symptoms does not fit together, we should consider whether more than one disease process may be occurring. In this patient, separating the chronic progressive symptoms from the acute change in presentation allowed both pathways to be investigated without prematurely attributing one to the other. Our key takeaway is when one diagnosis does not explain the entire clinical picture, resist diagnostic closure. Sometimes the correct unifying explanation is that there is no single unifying diagnosis. Thank you for your time and consideration of our case.